Now we will talk about the clinical feature of gastroesophageal reflux disease. Clinical features include heartburn, regurgitation, dysphagia, asthma, chronic cough, nausea and vomiting, and enamel loss. These two are very important. These are major symptoms. So the clinical feature of gastroesophageal reflux disease include heartburn, regurgitation, dysphagia, asthma, chronic cough, nausea and vomiting, and enamel loss. As in this disease, in the gastroesophageal reflux disease, there is backflow of gastric contents and which contain acids. These acids act on the enamel surface and cause the erosion of the enamel, and there will be enamel loss. So this is all about clinical feature. So now we will talk about the complication of gastroesophageal reflux disease. What complication can be caused by this disease? Complications include reflux, esophagitis, esophageal ulcers, esophageal stricture, Barrett esophagus, anemia, and gastric volvulus. So the complication of GERD includes reflux esophagitis, esophageal ulcer, esophageal stricture, Barrett esophagus, anemia, and gastric volvulus. So to understand the complication, let me draw a simple diagram. Esophageal reflux esophagitis, whenever there is a big flow of the contents, stomach contents, this is esophagus and this is stomach. Whenever there is big flow of the contents, so it will cause injury to the mucosa of esophagus and will lead to the inflammation of esophagus. So inflammation of esophagus. Which is called reflux esophagitis. Because of the backflow, we call it reflux esophagitis, inflammation of esophagus. And remember, this is the primary complication. Primary complication of gastroesophageal reflux disease. We talk about reflux esophagitis. Then esophageal ulcer is ulcer occur in the stomach, the duodenum. Similarly, the gastric contents, when flow back, it contain acids, so it will cause break in the mucosa of esophagus. It will cause break or lesion in the mucosa of esophagus and will lead to the formation of ulcer. So another complication is esophageal ulcer. Third complication include esophageal stricture. Esophageal stricture means narrowing of esophagus. Whenever there is injury, whenever there is backflow and it causes the injury to esophagus, so to heal there will be scar formation, and when there is scar formation, let's suppose this is scar, so the scar formation will make the esophagus narrow. This complication is called esophageal stricture, scar formation. Another complication is Barrett's esophagus. In this complication, what happens? The stratified epithelium. The stratified squamous epithelium is converted into metaplastic columnar epithelium. Here the epithelium of the esophagus, stratified squamous epithelium will be converted into columnar epithelium. This condition is called Barrett's esophagus and is the most dangerous complication because this is a pre-malignant condition. This is the most dangerous complication and it is a pre-malignant condition which can lead to cancer. Another complication is anemia. Due to esophagitis, there is blood loss. Blood loss due to esophagitis. And this blood loss will lead to anemia, iron deficiency anemia. And the last one is gastric volvulus. What is gastric volvulus? Abnormal rotation of stomach more than at 180 degree, causing the closed loop or obstruction. When there is abnormal rotation of stomach at 180 degree, which will form the closed loop or obstruction, this complication is called gastric volvulus. Let's have a review. We are talking about the complication of gastroesophageal reflux. Complication includes reflux esophagitis, esophageal ulcer, esophageal stricture, Barrett's esophagus, anemia and gastric volvulus. Reflux esophagitis, when there is backflow, so the acid content will cause the injury or inflammation to the esophagus, which is called reflux esophagitis. Esophageal ulcer, when the acid contents cause injury or ulcer to the esophagus. Esophageal ulcer. Esophageal stricture, when there is scar formation in the esophagus, it will narrow the esophagus, called the esophageal stricture. Barrett's esophagus, in this condition the stratified squamous epithelium is converted into columnar epithelium. This is the pre-malignant condition and dangerous complication of gastroesophageal reflux disease. Anemia, because of the esophagitis there is blood loss which lead to iron deficiency, anemia. And the last one is gastric volvulus, when there is abnormal rotation of stomach more than 180 degree, which cause a closed loop and obstruction. This condition is called gastric volvulus. Now we will talk about the investigation, which investigation or test are done for the gastroesophageal reflux disease. So first of all, include the history and clinical examination. We can diagnose the disease from the history and clinical exam. Number 2, endoscopy. Esophageal manometry. And the last one, biopsy. These are all the investigation for gastroesophageal reflux disease. History and clinical examination, we can go for endoscopy, we can go for esophageal manometry, we can go for biopsy. This esophageal manometry, what we do, we pass a catheter through the nose. Let's suppose this is nose. So a catheter is passed through the nose into the esophagus and measures the pressure of lower esophageal sphincter. A catheter is passed through the nose down to the esophagus, and we measure the pressure of lower esophageal sphincter, that how much pressure is created. And then we go for the biopsy. This is all about the investigation which are done for the gastroesophageal reflux disease. Now we will talk about the management of gastroesophageal reflux disease, how to manage. So the management, we'll talk about the management. Again, we divide into three. Non-pharmacological, pharmacological, and surgery, anti-reflex surgery. Three kind of management. Non-pharmacological include lifestyle modification. Lifestyle modification include, for example, avoid alcohol, avoid smoking, about diet, avoid using fats, chocolates, and the head of your bed should be raised 6 to 8 inches. And don't sleep immediately after eating. So lifestyle modification include, first of all, we should care about the diet. Avoid alcohol, avoid smoking, avoid the use of fatty foods and chocolates, and diet, weight control, your weight should be controlled. And during sleeping, your head portion of the bed should be raised 6 to 8 inches, raised in the ground, so that the reflex of contents should not occur. And don't sleep immediately after eating. So this is all about the lifestyle modification. If we have modified these factors, we can have a control on the gastroesophageal reflux disease. I must write weight control. Then after non-pharmacological, we will talk about the pharmacological. What are the drugs we use? So remember the treatment strategy for gastroesophageal reflux disease. The first thing, we should reduce the acids. And number two, we should increase the peristalsis. So that there is clearance of the esophagus and stomach. When there is increased peristalsis, there will be clearance of esophagus and stomach from the contents. So our treatment strategy is these two. Now on the basis of our treatment strategy, we are going to give the drugs. To reduce the acids, we give the drugs like antacids. We give the drugs H2 receptor antagonist, and proton pump inhibitor. To reduce the acids, we give these drugs. To increase the peristalsis, we will give the drug prokinetics. Prokinetics are the drugs which increase the peristalsis. So when there is increased peristalsis, there will be clearance of esophagus and stomach from the contents. The example includes domperidone and metoclopramide. So for the pharmacological, we are giving these drugs. Anti-reflux surgery. So there is a procedure or surgery which is called Nissen fundoplication. There is a special type of surgery which is named Nissen fundoplication. In this surgery or in this procedure, what we do, the upper portion of stomach is wrapped around esophagus to tight the lower esophageal sphincter. What we do, for example, this is esophagus, this is sphincter and stomach. The upper portion of the stomach is wrapped around the esophagus and is sutured. So there is increased pressure on the lower esophageal sphincter. So the lower esophageal sphincter is become tight and the pressure is increased. So this procedure or this surgery is named Nissen fundoplication. Let's have a review on the management. Management divides into three categories: non-pharmacological, pharmacological, and surgery. Non-pharmacological includes the lifestyle modification, avoid alcohol, avoid smoking, avoid chocolates, fatty foods, and the head of the bed should be raised 6 to 8 inches. Don't sleep immediately after eating, and weight control. Pharmacological includes two categories of drugs: drugs which decrease the acids, drugs which increase the peristalsis. So these three are the drugs which decrease the acids: antacids, H2 receptor antagonist, proton pump inhibitors. And drugs which increase the peristalsis are called prokinetics. Example includes domperidone and metoclopramide. Then come to the anti-reflux surgery. The procedure is called Nissen fundoplication. And what we do in this surgery, the upper portion of the stomach is wrapped around the esophagus. So the lower esophageal sphincter is tight. In this video lecture, we completed the gastroesophageal reflux disease. I hope you learned. Thank you so much for watching the videos of Easy to Learn production, which provide you what you need. See you next time.